on the right side first. So both the right and left coronary arteries come out of the aortic arch. So we'll do the right side first. The right coronary artery, the RCA, the right coronary artery, as you can see here, passes in the sulcus between the right atrium and the right ventricle. So that's where the right coronary is found. It's in the sulcus there. That sulcus is called the atrioventricular sulcus. There's a small gap between the atria and the ventricles, and that's where the blood flow is. Now, these vessels right here are not named. You see that? That does not mean that they are not important, but they are not named. So that vessel right there is actually the SA node branch of the right coronary. It's going to the structure that supplies the rate. I won't ask you to know that, but I wanted you to know these things are not all named. Okay, the right coronary artery, as you can see then, gives rise to a major branch. A major branch of the right coronary artery is called the right marginal artery. I said that on purpose because there is in fact also a left marginal artery. Okay, so the right marginal artery is a major branch of the right coronary, and it's going to run all the way out to the apex of the ventricle. So the right marginal artery is on the, it supplies part of the right ventricle. It comes off the coronary from an anterior perspective, from the front. You can see the right marginal coming off here, and it does actually pass all the way down to the apex of the right ventricle. If you continue in the right marginal artery, it will continue in the posterior atrioventricular sulcus, and you can see this picture here shows it shaded because this is on the back side of the heart, and it will actually anastomose in the posterior portion of the atrioventricular sulcus with the circumflex artery, which is a branch of the left coronary. And before that anastomosis is made, it will give off its second major branch. That is the posterior interventricular artery, passing along the posterior interventricular sulcus. So, I've said a couple of words I need to emphasize. Between the atrial masses and the ventricular masses, there's a groove, and that groove is called the atrioventricular sulcus. Makes perfect sense. There is also a groove that exists between the right ventricle and the left ventricle, and that groove is called the interventricular sulcus, the groove between the ventricles. That makes perfect sense. This blood vessel, the posterior interventricular artery, is in the groove on the back. So if you're already guessing with me, you're good. The one that's in the front groove is called the anterior interventricular artery. Okay, so let's get to that one. So the left coronary also comes off the aortic arch, and you can see the left coronary here is going to give rise to two major branches. Did you hear that on the right side? I said the right coronary artery gives off two major branches, the marginal and the posterior interventricular. On the left side, the two major branches are the circumflex and the anterior interventricular. So the circumflex artery comes off here, and it's going to make an anastomosis with the right coronary. The circumflex vessel passes in the sulcus and anastomoses with the right coronary. So I ask you, is there a way to get blood from the left coronary artery into the right coronary artery should there be a problem? Yeah, this is a major safety net, just like the circle of Willis in the brain. The heart says this is really important, and so you can get blood there from all directions. The right side into here, left side into there, the system is connected. Now, the circumflex also gives rise to a major vessel passing along the left ventricle wall. This one, not labeled here, is called the left marginal artery. The reason I mention it is because it is also often a bypass vessel, a vessel that needs to be dealt with, the left marginal, which comes off the circumflex. And save the best for last, the most important artery, the number one blood vessel where there is blockage found in human hearts is this one, the anterior interventricular artery. It is clinically referred to as the left anterior descending. In every echocardiogram that you will see clinically, it will have the letters L-A-D, left anterior descending, the anterior interventricular. It is also commonly referred to in clinical settings as the widowmaker. And you can see the gruesome nature of that description. How many men blockage in this blood vessel has killed? The left anterior descending artery, passing along the anterior interventricular sulcus. Now, last piece here, and then we'll move on to the veins. As it turns out, I have mentioned this, there is a lot of variability in circulation. And the heart is one of the most remarkable structures for variations in terms of where the blood vessels come from. So I have taught you the model, and you think, well, that's really what I'm going to find most of the time. But as it turns out, some of these blood vessels, like the posterior ventricular, come off different places in an astoundingly large number of individuals. So I'll not go through the numbers with you, but what I have taught you here roughly estimates what you would find in 2/3 of the human population. Does that bother you? So 33% of the population is going to have blood supply, major arteries that come off different places. Up to 40% have variations up here high in the coronaries, and up to 35% have variations down here low. So there's a lot of variability, but you've learned the model of the majority. Here are the veins. I was going to talk about the SE node. I'll wait on that for just a minute. Here are the major veins. So the major veins are named pretty much the same up high. But for some bizarre reason, the veins that drain most of the ventricular mass have different names. Now, a lot of textbooks don't emphasize the veins very much because nobody really cares about the veins. The problem with the heart is with the arteries. But you need to know the major ones. So the major venous pieces that you should be aware of are the venous pieces that drain most of the heart mass. And they are, on the front side, the great cardiac vein, and on the back side, the middle cardiac vein. These are the two vessels that pass along with the anterior and posterior interventricular arteries. So that white picture right there, that white blood vessel right there, is the anterior interventricular artery. And you can see the great cardiac vein passing along beside it. On the back is the middle cardiac vein, and it passes alongside the posterior interventricular artery. Now, as these veins drain the myocardium, they pool their blood in a sinus in the posterior atrioventricular sulcus called the coronary sinus. And it's illustrated here. Let me show it to you from another perspective. A couple of pictures of this. Well, I thought I had a posterior view. I must have taken that out. Do y'all have a posterior view in your section of the heart?
There's an internal view.
Yeah. Huh. Okay, well, my apologies. Your text has a nice image of this. In the posterior view, you can see this clearly, this coronary sinus. The reason I wanted to mention it in emphasis here is because the coronary sinus opens into the right atrium. So tomorrow in the laboratory, when you're doing your dissection and you open up the heart, you're going to make a sagittal section like this. Whenever you open up your heart like this, you cut it sagittally so you can learn the inside pieces. I want you to find the 3 major openings in the right atrium. There will be an opening for the superior vena cava. There will be an opening for the inferior vena cava. And there will be an opening for the coronary sinus. That is the blood that is returning to the right atrium from the ventricular myocardium. The blood that has supplied your heart has to go back and get oxygenated again. And this is your access point from the coronary sinus into the right atrium. Now, in this section tomorrow in the lab, I want you to notice some things anatomically. So we'll start in the right atrium, we'll do these 4, and then I'll shut up. So the right atrium walls has a prototypical piece of anatomy that students should be aware of called the musculi pectinati. It is a combed appearance in the wall of the right atrium. It is a telltale sign. The musculi pectinati is a comb-shaped. It looks like the muscular wall has been combed. And these muscles are the characteristic anatomy of the right atrium. So notice those as you're looking at the right atrium. 3 holes, and notice the musculi pectinati. Now the only other thing that I will ask you to learn in the lab, I want you to be aware of, in the wall of the right atrium, is a small indention in the wall. An indention that used to be a hole. Now can you tell me? Can you guys tell me? Can you guys tell me what that indention is? So when we learned field circulation, we saw these major differences. The ductus venosus connecting blood from the liver to the vena cava, the foramen ovale from the right to the left atrium, and the ductus arteriosus connecting the pulmonary trunk over to the aorta. So if there's an indention in the medial wall of the right atrium, what did that used to be? The foramen ovale, yeah. And so it will be labeled in your lab manual as the fossa ovalis. It is the remnant of this hole that used to go through from the right to the left atrium. Okay. So from the right atrium, we pass into the right ventricle. And as we do, we pass through a valve. And this valve is called the tricuspid valve. It has 3 cusps. And you should label them as you are working your way through. That's the left. This is the right. So you should label the cusp of this valve. I think I've got another picture of the cusp. I do. The tricuspid valve has 3 clearly definable cusps, an anterior, posterior, and a septal cusp. So it's important for you to identify the 3 pieces of this valve. It is a tricuspid valve on the right side, leading into the right ventricle. So here's labeled for you again, tricuspid valve. Now notice this tricuspid valve is anchored. The doors, the cusps of the valve, are oriented into the ventricular chamber. And they are anchored by way of ropes. These are collagenous extensions of the valves, very strong. They last a lifetime, connected to these swellings in the ventricular wall called papillary muscles, and those ropes are called the chordae tendineae, attached to the papillary muscles within the ventricular chambers. When the ventricular masses contract together, they force blood superiorly. And as the blood moves superiorly, it will push the cusps of these valves into the gap between the atria and the ventricles, closing that hole. So the blood will not go back into the atrial chambers. Instead, it will pass now from the right ventricle into what's called the pulmonary aorta, or the pulmonary trunk. So this little space is called the conus arteriosus. I think it's labeled somewhere else here. It is right there. So this blood will now pass up this way into the pulmonary trunk. And you can see here there's another valve. This one also has 3 cusps, but this one is arranged like a parachute. These cusps are arranged like a parachute. There are no cords attaching them. And these parachute structures give the appearance of a half-moon shaped cusp. See the half moons? See the half moons? So those valve cusps are called semilunar cusps. The semilunar valves here, one in the pulmonary trunk and the other in the aorta. So blood goes to the lungs and then it comes back to the left atrium, back over here to the left atrium. And from the left atrium, the blood passes into the left ventricle. It passes through another valve here, and this valve is called the bicuspid valve, or the left atrioventricular valve. It is also commonly clinically referred to as the mitral valve. So you can see here it's labeled the bicuspid valve. The mitral valve. Here's another shot of it. No, this is on the right side. Here it is. Good. So here's the mitral valve, or the left atrioventricular valve. So you can see it has 2 distinct cusps, an anterior and a posterior cusp. And these cusps are connected, like the right side, to the papillary muscles. Now, the left side's bigger normally and stronger. And so as the blood contracts and moves from the left ventricle upward, it's going to close this valve. But sometimes the valve itself can be damaged or weakened by any number of different pathologies. And if that's true, then blood will sometimes, when this valve closes, leak into the left atrium. Now the closure of these valves makes noise. And if you put a stethoscope on your chest, you can hear them closing. So the ventricles contract. And when they do, when the ventricles contract, the blood moves this way. As it does, this valve and this valve will close nearly simultaneously, but not exactly. So we're going to do more of this in physiology because I'd like for you to hear this with your own ears. You listen carefully, and the way you breathe, you can actually separate them. But collectively, this is known as the first heart sound, lub, the closure of the AV valves, preventing blood from going into the atrial chambers. Now, if the mitral valve, as I just indicated to you, leaks, you'll hear it here. Immediately following the first heart sound, if you hear something else through the stethoscope, that is most of the time a problem with the left atrioventricular valve. The most common heart murmur, called mitral valve prolapse. MVP is a condition where the blood leaks through the left side from the ventricle into the atria. It's a 2-cusped valve. This is one of those questions. You know, I've got questions for the Creator. My first question is, why don't you just put why didn't you just put the hormones in the kidney that were sensitive to blood pressure? Why do we have to use 4 different organs in order to do this? Good question. I don't know the answer to that. I'd be interested in knowing. Here's another one. If the left side is stronger, why not put 3 doors on the left side and 2 on the right? I don't know. But this is what we find. 2 cusps on the left side. And then finally, blood flows from the left ventricle through the aortic valve, which is also a semilunar valve, exactly the same anatomy as the pulmonary semilunar valve. Now, as the blood passes from the right side into this one, and the left side into this one, from the right side into the pulmonary trunk, from the left side into the aorta, as it does that simultaneously, the ventricles are then going to relax. And the blood in these vessels is going to want to come back into those chambers. But it is not allowed to do so. because these parachutes will open and close the hole. That will also make a sound. That is the second heart sound. So the heart goes bump, 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 bump. The first sound is the closure of the AV valves, and the second sound is the closure of the semilunar valves as the blood is exiting the heart. Okay, the last thing, and this will help me get started in physiology. There's a system of electrical nervous system pieces within the heart masses that we are going to spend a great deal of time with in physiology. I will not ask you to know them for this exam, but I want you to see them, okay? Because I'm going to spend a lot of time talking about them. Whenever we do heart physiology, I will begin here by saying, remember in anatomy, you learned all the anatomy of the heart. Now, let's talk about what makes it go. What makes the heart go is a series of structures located within the muscle mass that self-stimulate. And they are up in the roof, the pacemaker, the SA node, down in the floor of the right ventricle, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers that innervate the heart mass. These are anatomical structures within the mass of the heart that serve as the heart's very own nervous system. These have autonomic innervation, but you do not need it. They will go on their own without input from the autonomic nervous system. Okay, and that's what we're going to measure. We're going to do this in the lab, and you're going to be able to explain every piece of this book in human physiology. What caused this to happen? Okay, we've got about 10 minutes to talk about the exam. I'm finished with the material and prepared to give you an exam on Friday. Do you have questions? And what say you, young people?
So everybody decided for the exam to be on Friday?
Remember if we talked about it? Yeah, we didn't talk about it.
So what y'all gonna do?
Okay, show of hands. Who wants to say?
Yes.